Good evening, everyone, and welcome to another edition of the Rheumatology Nurses Society Town Hall. I'm Kevin Lyons. I'm the Executive Director of the Rheumatology Nurses Society, and I just want to welcome you tonight. We appreciate you taking this time out on these Thursday evenings as we go through updates and news and information as we share to you. We've had a lot of different changes with our Town Hall format recently, and tonight we're going to do something a little bit even more different. So this is a great time to take a moment and let us know where you're from. Leave a comment, take the feed and share it out to your friends, share it out to your colleagues. We have a really special night tonight. Also, make sure you give us some likes and some hearts. Let us know that you're out there. And don't be afraid to ask questions. And even though we're going to be talking about a specific kind of topic and we're going to do a great interview tonight with an amazing nurse practitioner, we also want to hear from you. So if you have questions about upcoming events, if you have questions about rheumatology nursing or advanced practice providers, if you have questions specifically for the RNS or whatever, definitely leave them in the comments. And we'll be monitoring those comments tonight and pulling those up. And if nothing else, just drop in and say hi and tell us where you're from. So we also, and don't be just a lurker. I mean, it's one thing to kind of like spy on things, but be engaged with us. Give us some feedback as we go forward. So we have just finished an amazing event, the Rheumatology Nurses Society 13th Annual Virtual Conference, just a couple of weeks ago. And that conference, you can still watch the replays for 30 days on the rnsnurse.org website. So I encourage you, there's like great educational content. And I just have to thank every attendee, every supporter, everyone who came and participated in that virtual conference. Thank you, because it turned out better than we could ever have expected. The board of directors and the educational planning committee, they put together a phenomenal program, and we had great supporters. We had great product theaters. We had Paint a Picture with Leslie. We had yoga every morning with Julie. It was just phenomenal, and it was such a great experience. So thank you all who participated in that. And it was such a great experience that we have something else coming up for you. So the RNS, if you've been a member or if you've been participating with us or supporting us over the years, you know that we're big on live events. And when COVID came, the board of directors and all of us, we really had to get around and say, how are we going to not just address COVID from a clinical standpoint and a practice standpoint, but how are we going to really address continuing the mission and vision of the RNS in this non-live experience or not, social distancing and all this other stuff. So we said, you know what? We're not going to let that deter. We're not going to let that deter us. And I just had Siri speak to me while I was talking. Oh my goodness. She said that's not that nice. I have no idea what she thought I said. Anyways, so we're not going to let it deter us. And we did the virtual conference, but now we also have other events that we normally do, like our forum series, our dinner series, our advocacy summit, and we are now on track to convert everything to a virtual experience for our members, for rheumatology nurses, for all nurses, advanced practice providers. And so we have a very special event coming up in November. And hey, we got some hellos here. Hey, Mildred from Newark, Delaware. Nice. I've never been to Delaware. I would love to make it to Delaware sometime. Thank you for joining us tonight, Mildred. And then we also have, this is from so there's the Rheumatology Nurses Community private Facebook group. And we have someone from Missoula, Montana. I would love to go to Montana. Thank you for a great conference. Thank you. And so in our private group, we have a little bit of a tech thing to where it says Facebook user here. So if some of our team, and we have moderators on our Facebook page, the Rheumatology Nurses Society page, as well as our private Facebook group and our YouTube channel. So if you chat in those there are moderators there. So if someone tells me who that is from Missoula, Montana, we'll definitely give a shout out. So coming up in November, this is so exciting, and registration is going to be opening very soon. So keep an eye out on our social media platforms. If you're not signed up on our newsletter, go to rnsnurse.org. But save the date, November 12th through the 14th is going to be the 2020 RNS Virtual Fall Summit. So what we're doing is taking all the great things that we did at our annual conference, the emojis, the pulse, the Q&A, the networking, and the amazing accredited education, because RNS is an ANCC accredited provider with distinction, and we take great stock and value in the quality of design of education, and we are producing the RNS Virtual Fall Summit. So that's shortly after ACR. You definitely want to check out ACR, but we are going, and I think that was Heather Marshall. Oh, thank you, Heather, from Montana. Thank you so much for being with us tonight. So we are going to take all the experience that you had at annual conference and expand on it, but do it in a shorter format. November 12th through 14th. Registration's opening soon. November 12th, I believe that's a Thursday evening, we're going to start. We're going to have some type of networking type of social thing. I can't say it's paint a picture. It might be something different. We're going to have product theaters, and we're going to have 11 educational sessions on that Thursday night, all day Friday, all day Saturday. Now, all day means like from 11, ish Eastern to 5-ish, Eastern, because, in virtual space, you don't want to do like a 10-hour conference. So we have that going on, and we have product theaters, 11 educational sessions, and attendees can claim up to 8.25 continuing nursing education contact hours. So stay tuned on that, because we're hearing that a lot of nurses and advanced practice providers, they're coming up a little short on their continuing education because there's not a lot of travel going on. They're not able to go to the other events and conferences that you're normally used to going to. And so we want to make sure that we are providing that amazing education, the accredited education that we do. And we are just about to release the actual educational design for that fall summit. We'll be announcing the agenda items here shortly. However, tonight we have, and so registration is coming soon, so be on the lookout. So tonight we have a very special guest, because one of the topics that we're going to be speaking at the Fall Virtual Summit, and right before I bring her on, we also have a lot of regional virtual events coming up soon. So keep an eye on the RNS website and the RNS social media feeds, because we have our workforce initiative is still moving forward strong. The RNS is in the middle of the fight of curing the shortage of workforce of rheumatologists in rheumatology by providing new rheumatology advanced practice providers, APRNs or nurse practitioners and PAs, as well as RNs to come in to help support the workforce. That has not stopped during COVID. We have at least 20 different programs coming up for different regions of the country, along with our continuing disease state education. We have more rheumatology nurse practice publications coming forward. We have a lot of things coming on, but the Fall Virtual Summit is going to be right in the middle of all of that. And we're doing this session on updated guidelines in treating patients with gout. So Nancy Eisenberger is going to be joining us here in just a second, and we're going to be talking about her session, and we want to get to know Nancy a little bit more. Nancy is an amazing nurse practitioner. She's also on the RNS Board of Directors. So without further ado, let's welcome Nancy. Nancy!
Hi. How you doing?
Doing great, Nancy. How are you doing tonight?
Doing wonderfully, thank you.
Awesome. Thank you so much for joining us. It's been an exciting couple of weeks, a couple of months really, and for RNS, and you're, one of the newer board members on the RNS. And so tell us a little bit about, you came into, the RNS, you joined the board, all of a sudden we're in this big pivot to a virtual conference. So tell us, what was your experience with the RNS virtual conference this year?
Wow, the RNS virtual conference was fantastic. It flew by. The information that we were given, that RNS put together, was stimulating. It was, full of information that was so useful in practice. I was so impressed. I'm so excited for the next conference. I'm thrilled to be able to present at the next conference too, but it was mind-blowing. For it to be a virtual conference and to have the quality of speakers we had, the quality of content, and to make it fun and like I said, stimulating. You didn't want to miss a beat, and it was put together in a way where you still had time for your life on top of it. Right. It didn't take away from anything in your life. It was great. I was thrilled with the format, the content, everything. It was fun.
Awesome.
So,
I know that, we're passionate about live events and in-person events. I mean, how, for someone who maybe didn't participate in our annual conference, how would you describe the engagement? Was it like watching the video all day long, or did you feel like you were there?
I felt like you were absolutely there. There were so many ways to participate. You could type in questions, and at the end, the speakers were there to answer. We could express ourselves. We could be happy, sad, upset. If there were some very minor technical difficulties at times, we got resolved very quickly, but we could express how we felt about those things. We could let you know if what was going on. It was really, you were there. You were right there with everybody. You saw, yes, we couldn't see our friends to be there, hugging, but we could see our friends, and it was nice. We could express ourselves with our friends that we don't normally see, that we normally would see, but we haven't seen in a while. So it was cool. It was really, really cool.
That's so awesome to hear. And it felt like, I mean, we also have the Rheumatology Nurses Community private Facebook group that a lot of the conference attendees joined in with. And it was rewarding because we didn't know how would this translate, right? We know that we can do a webinar. We know we could do a video or a Facebook Live like we do on, these Thursday nights. But how would a full conference translate? And we were just, it was the board, it was our staff, it was the team and everything else. But it was really the attendees and the presenters. When it all came together, it felt like community. It felt like we all kind of were listening and hearing and interacting with each other, which was great. So a couple of things about Nancy. First off, you're a nurse practitioner, and you're at the Arthritis, Rheumatic, and Back Disease Associates in how do you say that town in New Jersey?
Voorhees, New Jersey.
There you go. And
I believe.
Nancy Eisenberger currently resides in New Jersey, where she works as a nurse practitioner at Arthritis, Rheumatic, and Back Disease Associates. She studied nursing at the say it again for me, Nancy.
It was College Misericordia then. Now it's Misericordia University.
There you go.
I'm old.
And graduate nursing at the Medical University of South Carolina. She has been practicing rheumatology since 2006. Nancy has 3 amazing adult children and recently added a granddaughter to her life. Congratulations. Yay. She is passionate about her family and her career and loves taking care of people around her. Nancy, I'm just so thankful that you're on tonight with us as we start talking in the future. So, about the virtual conference, but this is not just about the virtual conference. We have some questions that we would like to ask you. Is that okay?
Absolutely.
All right, so we know where you work, and we know that you're a rheumatology nurse practitioner, but tell us, what is your current role as a healthcare professional?
So I see patients, I work with 15 physicians and myself. We all see patients. I don't see new patients, but I see patients just like the physicians do. And if some patients see me as their only rheumatology provider, but I'll have them see a physician once a year just for Medicare purposes, billing purposes. I see all disease states in rheumatology. I have a few that I'm a little more passionate about than others. I love psoriatic arthritis, sorry about that. I love RA, I love gout, fibromyalgia. I think most disease states in rheumatology, though.
Awesome.
And I love my patients.
For workforce, some of the things that we have been working on, with the RNS is modeling different pairing types of using advanced practice providers in practice. So you said you worked with 15 rheumatologists, and are you the only advanced practice provider?
I am the only one, and yes. So the way we model our practice, my plan was to be able to pair up the doctors with a nurse practitioner, and that was going to be what we originally did. It was interesting because where we're located, we're 20 minutes outside of Philadelphia, and we were able to hire rheumatologists, which is really rare because nobody can find rheumatologists. So since I joined the practice just a few years ago, we were able to hire about 4 rheumatologists. So my plan hasn't really worked yet. But eventually, I hope to bring on more advanced practice providers to our practice. We have 6 offices, so.
Oh, wow. So are you considered a group practice, or?
We're a private group rheumatology practice, so.
Gotcha. Now, are you a part of a mega group or anything, or is it just your own group?
It's our own group, but we belong to other, we belong to the mega groups, but we're on one single private group.
Gotcha. So, I won't ask exactly, but when did you get involved in rheumatology, and were you in another specialty before that, or what was your background?
Absolutely. So I started off right out of nurse practitioner, I have my nurse practitioner training, and internal medicine and hospitalist.
Wow.
And then went to a urgent care family medicine area. And I met a rheumatologist at a dinner meeting, at a fibromyalgia meeting, and I was seeing a lot of his patients, and they loved me. And he said he just lost his nurse practitioner. And he said, did I ever consider rheumatology? And I said, I couldn't stick a needle in somebody's joint. I would never consider rheumatology. And he said, why don't I just shadow him once and see if I'd consider rheumatology? And I took him up on that, and then I ended up working both jobs for 3 months until they could find me a replacement in my other job.
Wow.
And I don't regret it. It's the best thing I ever did. I couldn't imagine doing anything but rheumatology.
Wow, that's an amazing story. So before you were a nurse practitioner, did you practice as a RN first, or did you go straight into school for nurse practitioner?
I did. I practiced for, I guess, 3 or 4 years prior. More. I'm sorry, it's quite a bit more. It's 9 years. And I raised my kids, and I didn't work a lot. I worked nights, weekends, just kind of to keep my skills up, and just to make a little extra money and do those things. And then once my kids were in middle school, I went back and got my got my graduate degree in nurse practitioner certificate.
Wow. And that's when you were, as a nurse, were you a hospitalist, or what type of setting?
I did everything. I did a more flexible. I did a little bit of everything. So I had a wide variety of, skills or talents, and but never really found my niche. I worked in the offices. I did everything. Worked at the hospital. Anything I could, to do. But pretty much flexible in the hospital was mostly.
Well, and that's one of the things that we hear. We've done a lot of research in the workforce, and we are highly interested in how so we go to this conference, or we had been in the past. Now, because of COVID, we're not going to make it this year. NSNA, which is National Student Nurses Association. And when we go there, these are all the nurse candidates. So they're nursing students who are about to take their NCLEX, and they're about to become a registered nurse. And we're like, okay, how do we get them to have a knowledge of rheumatology, go and then come through the process? And it's interesting watching the progress of coming from the student nurse to the nurse, and especially if they choose to become an advanced practice provider or APRN. And it's interesting hearing that most of the rheumatology advanced practice providers that we talk to say that they go and they become an RN and they spend some time floating, and they might work in the hospital setting, they might work in primary care, they might do urgent care, and then they get that, they get that thing that says, I want to go further in my career. So it's exciting to hear that you kind of had a similar experience in that.
Absolutely.
That's so cool. And just checking to see, I thought I heard a comment come in, but anyways, no worries. So that's fascinating. So you kind of shared a little bit about what brought you into rheumatology, but when you came into rheumatology, what made it stick? What was your first impression, with rheumatology?
So, the thing about rheumatology, and I think this is what the selling point for rheumatology is, you build relationships. And so from my very first patients in rheumatology, they contact me on Facebook. They still thank me. It's life-changing. You leave an impact in people's lives, and they leave an impact on your life. When you have a patient who is in a wheelchair and you can help them get out of that wheelchair, it's life-changing. When you can have a patient who's been in pain all their lives and people have been giving them opioids, and you can get them off those opioids, and put them on medication and help them reduce their pain and have relationships in their lives again, it's life-changing for yourself and for that patient.
Wow.
There's so much gratitude in both for the patient and yourself. So, and it's one way, it's almost a selfishness to yourself, because I have fun every day. I go to work, I don't feel like I have a job. I have fun, and the patients appreciate you. And that's why my colleague that told me, come shadow him for a day, he gave me a gift that I could never repay, because that's exactly what it is. It's a career that it's selfish. My job is selfish for me because it changed my life, and I change other people's lives. So it's just it's incredible. I just have fun every day.
That's so awesome. I mean, when you find your passion, whether it's in healthcare or anything, I mean, that's when you soar, right?
Yeah.
That's when you're fulfilled and you press into it. And that's so amazing. So we talked a little bit about, you shared, you like psoriatic arthritis, you like RA, you like gout. You've mentioned fiber a couple of times. I mean, what draws you to these disease states? I mean, what are some of those disease states that you just feel, kind of like you can't get enough of?
I get to play detective. I have to use my brain. I have to really think it through, solve the problem, and then I can give life-changing treatments to my patients. I can take them, it's like I'm a magician. I could stick a needle in a joint and let them walk out of my office pain-free. And then I can prescribe them things that can keep them pain-free or reduce their pain. And I can talk to them and teach them and give them a better quality of life. I can help them, convince them to get over their fears, to take things that they didn't want to take in the past, and let them, help them get through their psychological, their fears and things like that.
Right.
And it's wonderful that you can educate and help people grow and grow yourself at the same time. So it's a symbiotic relationship, kind of. It's wonderful. It really is. It's a yin yang type of thing.
That's awesome.
It's nice. It's a balance, and so I'm helping them. It's wonderful. We're happy people. Rheumatology is at the happy field.
Yeah. Hey, we want to say hello to Brenda Borchard from Massachusetts. Brenda, thank you so much for being on with us tonight. We appreciate it. So, I mean, that's pretty interesting because, I hear that a lot. I have the opportunity of speaking to a lot of nurses, a lot of advanced practice providers, and there's so much satisfaction, in the field of rheumatology for you. If you're just joining us tonight, I'm on with Nancy Eisenberger. She is a nurse practitioner out of New Jersey, or Jersey, up there. And I'm Kevin Lyons, Executive Director of the Rheumatology Nurses Society, and we're getting to know Nancy, because Nancy is not only a board of directors member, but she's going to be one of the faculty at our upcoming fall summit coming up in November. So we're doing another virtual summit, coming up. And so with that, we were on a planning call recently, and we were asking, so, okay, what are you really passionate about? You're like, oh, fibromyalgia. And everyone was like, what? Because, that's kind of one of those, you either love it or it's something you have to do, right? But the other one was gout. So, I mean, what is it about gout that makes it very interesting to you?
So gout, the fun thing about gout is, there's a few fun things. For one thing, everybody, when you start, especially, men can get gout at any age, but it could run in families. But generally, you get guys about your age, Kevin, and they come in with a gout flare, and they take their medicine. We get them on medicine, and the flare goes away, and right away they think, oh, I don't have gout anymore. And they flare, they're in horrible shape. And gout flares, it's one of the most painful types of arthritis. You think about little needles sticking into your joint. It's horrible.
Wow.
And it's education. So gout is filled with education. We have to convince you must take your medicine. It's not, this is not going to go away. This is your gift for life. Diet doesn't really change it. We could decrease your uric acid by 1 point by changing your diet.
Wow.
Medicine is necessary for the rest of your life. And, you're a guy, and it's a male disease until after menopause. So, a 50-year-old, guy. It's more of a 50-year-old guy disease rather than a 40-year-old girl disease, because menopause doesn't happen until about 50 or older. And so it's really tough to get people to do what you want them to do, because you're not going to take medicine until you really have to, right?
Right.
Pretty much.
I mean, we're guys. It's like, you ask my wife, she's like, to get you to do anything.
Do we need to do this? Yes. Okay, well, you feel better? Why do I need to do it? She doesn't know what she's talking about.
Right.
What's this chick really, what's she saying? And so it takes so much education and so much, really, we have to put our hearts into this and really go through this over and over again to really get our patients to understand this. And even though primary care docs can write the same prescriptions, they don't really understand when to tell patients they need to take their medicine and when not to. So it's a real simple disease to treat, but it's a hard disease to get the patients to do what we really want them to do. And to even, like I said, the primary care docs are not really always in line with what they're supposed to do. So patients are getting really mixed information. There's a lot of misinformation on when if a female comes in at age 30, if they truly have gout, then they have kidney disease, really bad kidney disease, or they might have, it might be a confusion of their proper sex at birth. There might be things like that. There might be a lot of something is not right here, and we have to really it's a lot of detective work and figure out what's going on. So it's a fun disease to really. We have to work. It's not as simple as just giving the medication that's, a simple medication that's prescribed and it's going to go away.
Right. And there's different severities of it. And some of the things that we've learned through some of our, Gout for Patient Access and some of the other patient groups is there's a lot of shaming in that disease as well. You mentioned there's such a small percentage that you can control by diet, and to where a lot of patients don't come forward with the gout, because they feel that it's because they drank or it's because they had a bad diet, and so there's this guilt associated, right?
It used to be the rich man. It used to be the rich man's illness, because it's because you ate rich foods and you drank too much and this and that. But it's really not. It's hereditary. It's how your body excretes uric acid, or how your kidneys produce uric acid and things like this. So there's so much more to it than just simple uric acid. And so there's a lot of education involved. There's a lot of medications have gotten very expensive for it. That a medicine that used to cost $10 for 100 pills is now $3 a pill. Colchicine, things like that. So it's gotten a lot more complex. Yeah. And we have to be creative for our patients on how we're going to treat it too, based on that. And the guidelines have changed. We used to think below 6 was the number, and below 6 isn't the number anymore. Whether it's tophaceous, then the number has to be lower now. And the guidelines have changed a couple of times. We have new guidelines this year, which that'll be what we're presenting. So
awesome.
It's going to be fun. There's a lot. Stay tuned. We're going to be talking about this in our talk.
You may not have the answer to this, and again, I'm not a healthcare provider. I just kind of live in the rheumatology space. Mm-hmm. I know that there was conflicting guidelines from the American Medical Association and the ACR, American College of Rheumatology, back a couple of years ago. And I know ACR, American College of Rheumatology, just released their 2020 guidelines recently. It'd be interesting to hear, you don't have to answer now, but maybe it's something to point out in your presentation. Did that correct the differential between those two earlier guidelines? Because I know that they had some conflicting views in them, right?
Yeah, there were before. And as far as the new guidelines, you'll have to stay tuned on that one.
There you go. You're not going to give away your secrets. So definitely you want to catch Nancy in this presentation coming up. Just want to shout out to one of our most faithful viewers, Barbara. Good to see you from Cleveland. Barbara doesn't miss a town hall. We thank you so much. And Barbara also says, so Barbara has shared with town hall before that she has been diagnosed with ankylosing spondylitis, and now she's saying that she's found out she has fibromyalgia along with ankylosing spondylitis. Wow. It's
very common. That's one thing that fibromyalgia is a tag-along to many of our autoimmune diseases, and very often people with ankylosing spondylitis are diagnosed with fibromyalgia, and ankylosing spondylitis is missed. So you are fortunate, Barbara, that they caught the ankylosing spondylitis first, because that's one, if you don't catch it, then you have big problems. So it's good that your provider caught it first, and then they're treating both. So
Awesome.
hope you do well.
Good to have you, Barbara, as always. As always. So, so you're going to be sharing with us at the Fall Virtual Summit, on gout, and talking through, the guidelines, talking through some of your other findings. I mean, I'm sure you'll share some great case studies coming up. Now, fibromyalgia, you said that that was one of your other favorite disease states to treat and help people with and stuff. Because fibromyalgia it's kind of nebulous, right?
It's basically a central pain disorder, and it's very, very real, and it's very devastating for so many people because for years it was getting missed or overlooked, or people played it down. But it's something that's so it's devastating and life-changing, and basically. It needs to be treated. It needs to be recognized. Well, we have to look at the entire person when we're looking at a disease, because so often people have, RA and fibromyalgia, lupus and fibromyalgia, spondyloarthropathy and fibromyalgia. And if we don't treat our whole patient, we're not treating a patient. We have to get rid of their pain along with their inflammation, or they're not going to feel good. And the whole thing is about making patients have good quality of life, and that's our bottom line. If we want to feel good, we want to be able to take care of our families, take care of ourselves, enjoy life. That's that's the bottom line.
An interesting thing about feeling good. We were having a conversation internally, not from a medical standpoint, but with one of the pharmaceutical companies, and there's a whole discussion about, is feeling good enough? And do patients get to that point? Because you mentioned earlier in our conversation how you help patients become comfortable going on different therapies, and this dialogue was patients, or the scenario was patients many times do not know that they could feel better, or they are so concerned about switching therapies that they feel good enough. Do you experience that in clinic?
You're 100% correct. That's exactly it. Patients. That's my biggest thing is I feel you have to educate. Like I had a patient today who came into my office with RA, and she was an older woman, and she tried hydroxychloroquine, and she had side effects. She just felt bad on it. She said she's not going to take anything else, and 2 other providers said, okay, you don't want to take anything else, fine. And when I saw her today, I said, why don't you want to take it? So what's the worst thing that's going to happen? You felt dizzy on hydroxychloroquine. I get that. What if I start methotrexate? What are you afraid of? I'm afraid it's going to make me feel the same way. I said, so if it does, what's going to happen? We'll stop it. And her daughter was there. She was about 81 years old, and she had terrible inflammation. And she thought about it. I said, do you want to stay this way? Do you want to, have no quality of life right now? And, and she looked at her daughter, and she said, okay. And she started, anyway, I had a very nice, warm heart-to-heart with it. But when you bring out the ghosts in the closet and say, those ghosts aren't going to hurt you.
Right.
They're willing to. You have to bring out the facts. And when you bring the facts out, people are willing to do it. What's the bad and what's the good? Mm-hmm. But if you just say, okay, I'm not going to take it, and you say, okay, well, of course you're not going to take it because, there's nothing else that's going to be said. But if you expand the conversation, you can get people to do what's necessary to feel good.
So that's those interviewing skills that you develop. Right? How to actually get the patient to open up and share that information. That's fascinating.
Yeah. But that's it. So that's how you can make somebody feel good enough, or better. We have to take that next step because it's not, at least I can't live with somebody walking out of my room not taking that next step, or at least me not trying to get that next step, without, it's just not in my, not the way I provide medicine.
Right. Well, speaking of ghosts in the closet, COVID-19, right? So how?
Yes.
I know, right? I think we're COVID. It was a terrible hurricane that came up through Louisiana yesterday, and we're in Florida. We were watching that hurricane coming up, and it's like, okay, it's 2020. There's 2 tropical storms in the Gulf of Mexico. There's murder hornets, all this other stuff. and then COVID-19, is there. It's just what a crazy year that it's been. And I think everyone, New Year's Eve for 2021 is going to be probably an amazing celebration. So how has COVID-19 impacted your practice?
So majorly. We had to make some major changes, in which we did. We started video and telecall, televisits when possible. We plexiglassed everything, and I even do some house calls. I do drive-through Prolia, drive-up Prolia injections. So I do I do a telephone call with my patient, or a video call, and then when they come, they drive up to the parking lot, and I'm masked and gloved and gowned, and I give them their Prolia in the car. We try our best to do things that can accommodate patients the best way possible, and keep staff safe, keep patients safe. We work our staff in pods. So if somebody, we've had only one staff member come down with COVID, and so just one, which is amazing, we're huge. Our practice is huge. So it's great. But like I said, so if when a staff member comes down, everybody gets tested, quarantines and tested, and that. Our patients are screened with temperatures, things like that. We've took amazing precautions. We also, like I said, we accommodate our patients. If a patient has an elevated temperature, they can't come in. If they have a cough, they can't come in. We explain to them that it can't happen. But we made accommodations in every possible way. And but we never, our numbers dropped a little bit, but we made sure that patients and staff safety first for everybody. Safety first. Right. And it worked. It's worked. We kept infusion. Infusion never stopped. Nothing ever stopped, but we did our best.
Yeah, it sounds like, Prolia drive-ins, right? Who would have thought? Because that's a sub-Q injection, is that right? Sub-Q
injection, but that's why at first we were trying to figure out you can't miss Prolia. It's, if you miss it by a month, it increases risk of fracture. And so it's one of the, a bisphosphonate you can miss, but, you could delay, but that one you can't delay. So those I'll even do house calls for. I'll go and, knock on the door and if a patient can't drive. So you have to accommodate patients any way you possibly can, if at all possible.
Right. That's fascinating. Barbara just shared that she's also being tested for Sjogren's syndrome, developed psoriasis and psoriatic arthritis, and has severe reaction to Humira for treating AS, diagnosed with only because my dad had it and kids and grandkids were tested. Only me and my daughter have the same gene with the positive HLA-B27 result. Yeah. Stranger part is both of us just happened to have a high male hormone count and showed signs during childhood. So, yeah, Barbara, wow, you have quite the journey going on.
Ooh.
Wow. We wish our best to you, Barbara. Keep researching, keep engaging with the rheumatologist and your rheumatology team. For sure. So with all of these innovations, Nancy, and with COVID, what are some of the most impactful things that you've learned through this pandemic?
So one thing is you even though it's invisible and silent, you take it seriously. Life is dynamic. And you take nothing for granted. That's right. The one thing is, you have to, but with a dynamic life, you roll with the punches, and that's what we're doing. Yep. That's what I've learned.
For sure. Yeah. And if you have any questions for Nancy, she's again a nurse practitioner, rheumatology nurse practitioner out of New Jersey. Feel free to leave them. But yeah, I think that's it. You take every day for its value. You never know what you have until you don't have it, right? Or you hope that you know what you have and before you don't have it. Exactly. And it's changed so much in across the country, it's different impacts. We have a board member who's in Oklahoma, and so they had a delayed thing. The city didn't really believe that COVID was a thing per se, or they didn't take it seriously, and then they have an impact afterwards. Even the hurricane that just came through, Louisiana, for the first time. I mean, we live in hurricane world in Florida, and they're like, go to a shelter, and go and be in these congregate environments. But in Louisiana, they're like, don't go to a shelter. Go to your friend's house. Go to a family member's house, to keep that, the social distancing, to keep, because the numbers are trending better, right? But there's been so many innovations. What do you think? So do you find that patients are ready to come back in, to the clinic, or are they preferring telemedicine?
So I now am seeing most of my patients in the clinic, because our clinic, we keep it, I mean, if you can't disinfect any more than we disinfect. And we can't wait in our waiting room. We wait in the cars. Mm-hmm. You wait in your car, you call in, you come in. We have that kind of system. But I still, that's mostly for injections. We do a lot of injections, a lot of joint injections. And we do have to see, televisits are great, but you still have to count joints. You still have to, especially if you're adjusting medications and things like that. And the one thing we've learned with COVID is the fact that you have to keep inflammation down. It's, if you don't keep your patient in good control, they're at higher risk. So I do, if I haven't seen a patient in 6 months, or since all this is going on, gosh, we've marched, till now, or 5 months. I want to make sure that I'm getting them in the office and touching them and looking at them, and especially if they're on infusion medicines and stuff. They have to come in for their labs. We have our lab in our office, so I'm trying to get them touched and seen. So we are seeing a lot more in the office, but we're making sure we're alternating rooms, making sure they're completely scrubbed down in between, and it's pretty safe. And a lot of our patients have already have had COVID, and they're doing okay. Our population isn't getting bad COVID. They're well controlled.
Right.
That's what we're seeing in the numbers. I'm sure you've seen that.
Yeah, that's fascinating.
We're very careful.
Are you seeing more aggressive disease progression, and disease activity because of the absence in the office?
I'm seeing a lot of disease activity from stress. I'm seeing a lot of fibromyalgia from stress. I'm seeing patients doing poorly, because of the way they're feeling. So I'm treating, and I also will treat their depression, anxiety, and things like that, because I treat whole patients.
Sure.
Yeah. So I want to see them in the office. I want to see follow-ups frequently because of that. I mean, I'll start them in on the phone and get them back in the office just to make sure that they're really doing okay and things like that.
Right. So stress, I mean, when you go through stress, your cortisol increases, epinephrine kicks in and all of that. And again, I'm not a practitioner, but I'm guessing that your patients that are on steroids and so forth probably see that impact, right?
Exactly. And we're also seeing post-COVID flares. We're seeing reactive arthritis from post-COVID, things like that. So we're seeing all sorts of funky things right now.
Wow. Mm-hmm. So fascinating. Oh, Karen McCarran, former other board member. She's here tonight. Hey, Karen, how you doing tonight? And she's excited to hear about what we have to share about the Fall Virtual Summit. So good to have you on, Karen. So it's probably a loaded question and you don't have to answer it, but so you mentioned that the patients that you're seeing that do go through COVID seem to do okay through COVID. I mean, I know you don't have the evidence behind it because there's not evidence to my knowledge behind it, but do you feel it's because of the therapies that they're on, or maybe their awareness of their bodies?
That's what they're, so right now the numbers that, what we're seeing from the numbers out there through publications, they're thinking probably because their disease is controlled, that they're not we're seeing, I've seen one bad outcome from somebody who stopped their medications. That was the only negative outcome I saw, was somebody who stopped all their medications, came down with COVID, and did not make it. And it was horrible. That was, a really very tragic thing, a very young person too. But our patients, like I said, I have very elderly patients on biologics who've had COVID and, didn't have bad outcomes.
Right.
The cases were not terrible they were sick when they had it, but they were not terrible. I'm seeing that in a lot of the publications that we're seeing patients on biologics that have not had terrible outcomes. That they're, and we're assuming that's because their disease is well controlled.
Right.
Their inflammation is well controlled. We don't know. We haven't. I don't think that full association has been made yet. Their studies aren't out there. I think there's studies that have to be done. Further analysis has to be done. But we're assuming it's because their inflammation is controlled.
Right. That's fascinating. It's interesting you say that, on the contrary to the patients, because, as a layperson or a patient, they may think I'm on a therapy that suppresses my immune system, so therefore I'm at higher risk of contracting COVID, so I'm going to stop the therapy, not recognizing that stopping the therapy is going to potentially put you into a flare or some other issue, right? Exactly.
The way I explain it to my patients is that we're really balancing their immune system, not suppressing their immune system. And, so their bodies are not having to do all the work fighting their disease. And when you stop this, their body is spending the time fighting disease. They can't fight an illness when you get it. So it's really the best way to kind of explain it. You need an immunosuppressant when you're sick, because you're already in a mini cytokine storm. Your cytokines are out of control, and maybe a cytokine windstorm, not a cytokine tornado that you have when you have COVID, or cyclone. So basically, we have to calm that down, as opposed and you can't do that when you have if you have COVID, you can't fight both.
Wow.
And so
fascinating. We heard a lot about that from Dr. Palma at our annual conference.
That was talk.
Dr. Palma, he was fantastic, and Monica Ritchie. And all of those sessions, if you missed annual conference, you can still register for the on-demand conference, and you can still get your contact hours. Go to rnsnurse.org, or one of our moderators will put it in the comments, and you can still register. And I think we still have some conference in the boxes left that we can send out if you register, if they're available. But you get all those contact hours, and the content was just so great. What we did is we did a combination of about 30 minutes of recorded video and 10 minutes of live Q&A, where we brought the presenter on live, and everyone was able to ask questions and interact with the presenter. And we're doing that same format this fall, at the fall comment. And so, Karen said, I'm doing well, cannot wait until we can get back to a little more normalcy, maybe actually attend a dinner series or conference. I know, Karen, right? Someday soon. And that's, we miss seeing everyone in person. We miss our dinner programs. We miss our conference. So thank you to our moderator. So rnsnurse.org/conference is where you can sign up for that. But for our annual conference, we had such a great response that we're doing it again in the fall. Not the annual conference. It's going to be November 12th through 14th. So a Thursday evening, Friday from around 10 or 11 a.m. Eastern to around 5 p.m. Eastern, and Saturday the same time. And we're going to have fun. We're going to definitely do some special things to where there'll be some networking opportunities. There will be some different things going on that they'll be innovative and fun. And if you've ever been to an RNS event, you know that we're all into creating a positive educational environment to where our accredited education gets the outcomes that we desire. So we believe in having fun doing it. So if you have any last minute questions as we're wrapping up tonight with Nancy Eisenberg, definitely drop them in. So you're doing updated treatments or updated guidelines and treatments, treating patients, not treatments, but treating patients with gout up at our fall summit. So just some takeaways here. It sounds like, I think we've known each other for a while, even before you were on the board of directors. Yeah. You've always been kind of in the center of so many different things in rheumatology. If you didn't come to our 2019 conference or 2018 conference, Nancy was there, and she was doing joint injection training, for us, which is phenomenal. And she always talks about her and Linda Grinnell Merrick, our former president. They love injecting joints. It's just like your thing, right? For sure. And let's see. So Barbara's asking, what do you say to your patients on biologic drugs that do not want to take them because of a life expectancy of 65. After a recent MRI, I had an urgent appointment made with my spine surgeon. I just saw him the other day and was told my spine and spinal cord was looking good and would probably not need surgery in my lifetime. Is that really good news? My dad lived to 83 and played ping pong a week before he went into the hospital, but he was not on biologics. I question being on them. That's a multi-compounded question there. So sounds like her dad did not take biologics, possibly had some of the other, diseases that she's, working through. She is on biologics, but she's concerned about taking biologics. So maybe, how do you have that, adherence, dialogue with the patient?
Yeah. So basically, the risks that we talk about with biologic medications are really the risks of the disease. So, when we look at the lymphoma, heart disease, stroke that we talk about on those warning labels are really the risk of inflammation. So if you're saying you have psoriatic arthritis now, as well as a positive HLA-B27, psoriatic arthritis and should be treated with a biologic, and those are not as long as your doctor doesn't see any side effects being caused by the biologic, which generally, like I said, they're more like our own body than ibuprofen, Aleve, which has much 40% increased risk of heart disease and stroke. They're safer. It's what you should be treating your disease with. Inflammation is what's going to get you. So, like I said, the side effects you're seeing on those labels are the side effects of your disease. So you need to do whatever it takes to keep your disease in control. Mm-hmm. So that's what I tell my patients. I explain that to them all the time. If you're having any activity of your disease, you have to do anything that's within the guidelines to keep it in control. And the guidelines say for psoriatic arthritis, that's using TNF blocker, or right now the other medications are the IL-6s, as well as the newer medications are the IL-23s. They're not indicated for the ankylosing spondylitis. So you're probably going to be doing TNF blockers because that covers both ends. You're going to be doing those as long as you can tolerate them. And they're much safer than taking NSAIDs or other, pain medication. So the worst thing you can do is take pain medication, opioids, or anything like that. You really need to take the disease-modifying medication. And I stress that with my patients. You need to do that. Have the fibromyalgia properly treated with things like, Cymbalta, gabapentin, and exercise, and really take care of yourself. It's not, you don't want to have any spine disease, and the only way to prevent the spine disease is to do the preventative with these medications. So that's what I tell my patients.
Yeah. That's a really sound advice. Barbara shared she's only 50, and that's young. For sure. So
we don't want to see spine disease. We want to stop it. So that's a good thing that you don't have it. And I'll be honest, I have 90-year-old patients taking these medications. So, yeah.
Awesome. So she was prescribed one medication for AS, and she had a severe reaction to it, which caused the psoriasis. So, and I think, some of that is you really have to lean into your, prescriber, your rheumatologist.
Yeah, I'll work with you.
Have those critical conversations with them to say, these are your concerns. I'm not a healthcare provider, but I am a patient advocate. My family members have gone through a lot of things, and one of the biggest values that we've been able to do is be educated. Ours is more in oncology and cancer and cardiovascular, but be educated as you go in, and not, be brave and ask those questions. Don't be combative. Don't try to show your rheumatologist, your, advanced practice provider that you know more than, or you're challenging, but have the critical conversations and be real with them. And if you're not getting the answers that you feel that you should get, don't be afraid of talking to another rheumatologist. Always, be proactive about your care and your treatment and stuff. And so we always wish you the best, Barbara, for sure. But, well, Nancy, we are just about out of time. So once again, I'm going to plug it. you don't want to miss the Fall Virtual Summit. It's going to be fantastic. We have a lot of surprises. Nancy is one of our presenters. We're going to be releasing the agenda here, pretty soon. I'm guessing we're days away from announcing the agenda for this conference. We'll have product theaters, we'll have an exhibitor experience, we'll have networking things. I'm not saying that we're doing paint a picture, but it will be either paint a picture or something like paint a picture, because I know that's just a great crowd favorite, that they come to our Artemis annual conference for, and we're like, hey, let's keep doing fun things. If you haven't joined the Rheumatology Nurses community, it's a private Facebook group where many of the conference attendees join, and we're starting to do some cool things in there on community building. And just, we have so much education that's in the pipeline right now. We have rheumatology nurse practices coming out. Check out our Learning Management Center. We have so many free continuing education credits on there. And if you're a member, we have tons of free community or CE credits on there. And then, if you haven't signed up to our mailing list, do so, because we have all types of publications and pieces coming out. The team is really excited, and the board, the educational committee, about all the throughput that's coming out. We're continually to deal with workforce. We have a great series on Dear Diary, talking with patient and provider dialogue, where advocacy is really ramping up, and you're going to be hearing about some advocacy events coming up here soon. So we have a lot going on at RNS. So Nancy, thank you so much for joining us tonight. Any last thoughts or comments?
No, it's my pleasure. Thank you for having me, Kevin. I really appreciate it.
Hey, it's an honor. Well, thank you all for coming, and we will see you soon.